really bad long term for the perio or whatever, I don't know. All I'm saying is this here is 107, the MP to a lower incisor plane, or manual plane, sorry. My opinion with a case like this one, which was about 88 here, we should have been somewhere in the middle at about 95, probably would have been good. So we overproclined by 10 degrees. Again, I can't tell you if it's terrible or good, but I think the planning could have been a bit better. So how can we do that? Well, I'm going to present you another case, and something I really liked is a systematic review that happened in 2015 from the University of Edmonton. My good friend Carlos Flores here published a systematic review, and I was surprised to learn that basically what they found in all these papers, that you can intrude the upper incisors easily by 1.5, and the real intrusion, I mean, and the lower incisors by about 2. So you get about a 3.5 millimeter window. You can do it more, but the average is about 2 millimeters and 1.5. So that's a good sign for the clinician to say, okay, to plan the case based on science, saying I cannot just intrude the incisors as much as I want. So that's a case, not exactly the same as the one I showed you before. That's one of my cases. So you see that you have 100% overbite. The patient is 15 years old. She's class 2, not severe, but class 2, and is not going to be growing on us. So then we're going to have to place the incisors in the best possible position in a phase to make the case as best as possible. So then I'm making the decision, because of this occlusal plane right here, that I want to bring the incisors up, and I want to accept a little bit of proclination because they are too upright on bone. And by doing this, I will do a small, and I want also, on purpose, I want the molars to actually tip back and maybe extrude a little bit. So I use a very simple system, a very simple intrusion arch, can make simpler than that. And then what we do, we tie it to the front because I want a bit more rotation. If you want less rotation, you can tie it to the back. So you'll have a more straight force with less moment. You can do many things with these. It's a very simple system. Be careful because you put a lot of moment on the molar. So you can't leave these mechanics for a long time. But I start with this. I don't open the bite. I do nothing. I just do, the first step is to intrude the teeth. And whenever the teeth are intruded now to the right occlusal plane, I can resort to some form of a normal straight wire system almost. And because on this case, I want these low incisors are retroclined, and I don't have the Ceph. I lost the Ceph pre-op, so I apologize. But these incisors were about 85. So I know the patient is not going to grow. She's good class 1 here, slowly coming into a class 1 occlusion here. So I want these teeth to actually procline and intrude. So I decide to use a simple straight wire system for a relative intrusion. So I did pure intrusion on the upper, and I decided to do relative intrusion on the lower on purpose. And I monitor everything. And if I don't like what I see, which happens sometimes, I will cut the wire and go back to an intrusion arch. But at the moment, this is what I'm trying to do. And you see the bite is opening slowly without much problem. So I let the I let the occlusion settle. I will keep the incisors here slightly retroclined because of the malocclusion, and we are camouflaging a class 2. So I'm not going to put the teeth perfectly procline, otherwise I will have to procline too much the low incisors. So this is what we do. And you can see that the result is pretty good. The teeth are a little bit more than 90 as predicted. These ones are a little bit less than we want on purpose. So they are a little bit retroclined. These ones are a little bit proclined. So it's a good camouflage because it's done. And the vertical dimension is pretty good too. So we had the result we were planning for. And 3 years later, obviously the bite closed back on me a little bit, which happens during settling, but the result is still fairly acceptable. and the patient looks pretty good. And yes, there is a gummy smile, but I think that in the case, she has a very active lip and the result is very acceptable. So that's the idea of a mix of pure intrusion and a mix of relative intrusion, depending on what the patient needs to be getting. So how can we do something like this patient here that is very retrognaathic, cannot have a lip seal, she's not doing really well there. And again, we need to do a vertical control of the dentition. So the dentition has to be controlled in vertical and AP as much as possible. And obviously, patient being an adult, you don't expect any growth. And the big idea also, remember that the straight wire system tends to be extrusive. You do not want to open the bite by extruding the molars, because otherwise we will get even a more deficient lip seal, and that will not be very interesting for the patient. And that's the occlusion. So again, these you see these all the time, where you have a class 1 molar, you say, well, the patient is class 1. In reality, if you are positioning the dentition correctly, these have been migrating mesially, so you have really what you have is a skeletal class 2. This guy has a class 1 molar. So again, that's a problem, because you need to understand that this relationship here is pretty good. You want to maintain it as much as possible, but obviously you will have a problem because the incisors are way up and they are actually in the, I would say, AP position, not poorly positioned. So it means the canines have to go back. This is what you need to do. So you need canines back, you need intrusion of the lower teeth, you need retraction of the upper teeth, and maybe a little bit of intrusion, which sounds funny because you say, wait a minute, on this picture you showed us that here there was a lot of gingival show, but the gingival show is actually caused by the prognathism of the maxilla. So it's not such a vertical problem, which is interesting. So again, you can study all these, and again, I'm not going to be plugging WebSFX software. That's not the point of the lecture today. But what I will tell you is you can do all this with a new system, which I played with. It's kind of interesting. I have no idea yet if it's clinically 100% relevant, but you can experiment anyways. So that's the problem we have, is if you use the 3D modeling, you have a two-step occlusal plane. So then you have to ask yourself, which one is a good one? You know, you already look at the facial features of the patient and you do not want this. That's the idea. So what we need is we need to intrude the teeth almost, and in this case, it's almost a pure intrusion, but it's over 2 millimeters, according to Dr. Carlos. So you say, well, maybe I would have to accept a little bit of proclination in this case, but not too much. So if you use a straight wire system in the case like this one, which I've seen do, what will happen is the canines will not move fast enough distally, and you will end up with a lot of proclination, and the teeth will be like so. And then you will have to retract them. Is it bad or good? I don't know. All I'm saying is, once the teeth are super proclined, you are what we're doing round tripping, meaning I'm pushing the teeth forward and then my mechanics will bring them back. That's as much as possible to be avoided. In a case like this one, I'll show you I made a few errors. I like to show when I make errors, so I learn from my mistakes. And I did do a bit of round tripping. So it's an important aspect of the concept is limit round tripping. And sometimes if you go proclination first, procline first, and then retrocline, it's almost the Beck technique all over again. So I don't like doing this. If I like what I see right here, this is the position. These teeth will actually go a little bit back, and this canines have to go a lot back. So I will start with And that's the, position of the teeth. You can see they are already pretty proclined. We trace them at, I can't remember, where are they? Here, 90 degrees. So they're 90 degrees to the occlusal plane. These teeth here should go a little bit up, but they have to go back a lot. So again, if you do canine premolar extraction and you are not careful, these teeth will tend to go this way, which is not what you want. So you have to plan to avoid the extrusion of the incisors. And again, to keep the teeth in the bone, I will be limited in the amount of retraction. I just cannot retract as much as I want, because otherwise I may end up taking the roots of the bone. So I will have to accept a little bit of proclination, which is planned in the case. So what do we want to do with these incisors? Well, the best thing for us to do is to try as much as possible to intrude them and almost keep them where they are, a little bit back maybe, but not too much. And that's what you want to do. If you use a straight wire system without looking, this is not going to happen. I'm going to change the color so you can understand better. This will happen. So you're not going the way you want. So this is the desired movement. This is what you want. This is what you want. This is what you get. Again, can you get this back by retracting? Maybe. But if you can avoid it, it's even better. So that's the arches. You can see again that those teeth are super high and these ones are low. And remember, you have to determine the occlusal plane. It could be here. It's almost impossible, but it could be. It can be there, which in the case is pretty much, or it can be anywhere in the middle. So you have to plan for this. So if it's this one, then you have to extrude the molars a lot. If it's this one, you have to extrude them a lot. But in this case, this is the good one. So you have to intrude these a lot. And it's more than 2 millimeters. It's 2.5, 3. So it's going to be difficult to do. So again, remember also incisor intrusion tend to have root resorption a bit more than average. So don't put too much force. Use a forge gauge when you use this system because you need 20 grams maximum per tooth. Again, if you use very stiff wires, it will intrude. The problem is you may get root resorption. So again, as I said before, we start very simply on the upper arch, extract premolars. And we just put a straight wire for now because we don't need any type of significant control. I just want to align the brackets. That's all it's needed for now. I will use something else later on for that intrusion, but at the moment I'm not doing anything there. And to avoid again putting any forces on the low incisors, I don't use a straight wire. I will just use a very simple system. I should, by the way, that's my error. If it was done today, I would put a lingual arch on this patient to control the molars better. I didn't do it then because she was a bit complicated to deal with, so we had to use very small brackets, and she was complaining all the time that she didn't like the brackets. So we used as little simple mechanics as possible. So the simple mechanics are very, very easy. We use, in this case here, we use controlled tipping. So the apex of the tooth was going to stay where it is, and you'll have rotation and a little bit of extrusion, which is what we want. So in a case, it doesn't mean it should be used all the time. This is what we are doing at the moment by putting a simple force here and putting a small counter moment at the level of the lower bracket, and that's by controlling the size of the wire and controlling the amount of force. It's a very light force, it's 3 ounces only. And then you retract the canines this way. It's not a pure translation. Remember, it's control tipping. That's different. Okay, I'm showing you this because that's wrong. I should not have done this. I did it because the patient again was complaining that she just wanted the brackets aligned, and I said maybe I can get away with a 9 tie. This was not a good idea. It has side effects, so I would argue that I don't use these anymore. I tried on this patient. I didn't like what I saw because I was getting proclination of the low incisor. So this one is my mistake. Don't use this. On this patient, maybe on some others, I don't know, but on this patient, you put too much proclination moment here. So the rotation is too much. So I use it for one visit, and I said, no, that's not a good idea. Even if it's more comfortable for the patient, I didn't like it, so I stopped. Well, then I decided to go for the intrusion arch. I could have used a 3-piece. Again, patient was not too happy, so the canine are slowly coming in. So what I'm doing is, now the importance of this arch is to decide, you have about 60 to 80 grams of force here, maximum. 60 is better. Sorry, I'm going to remove that. I made an error. And what you do is then you lift it, right? The big issue is, where do you tie it? Can you tie it here? Can you tie it here? Or can you tie it here? You can even make some extension if you want to. And the big advantage of tying it as distal as possible, is you will have more intrusion and less proclination. So it's a game between where you tie it. So you first is control of the force, but the force should be pretty much always the same. Again, 60 grams to 80 maximum. So you can increase or decrease the force. You should keep it in this length. So the force is not, the magnitude is the same. It's just the way you tie it. So by tying it here, you get more intrusion, less rotation. If you want rotation, you tie it here. It's all a matter of what you want. You make the decision yourself, and you can check it by taking another Ceph or looking at how the incisors are doing. I also sometimes look at the gingival margins. So this patient here was tied this way. See, I tied it here and here to start with. If I knew, again, a little mistake, in my opinion, it would have been better to tie it here, but that's not a big difference, or even tie it there would have been even better. I would have gotten better intrusion and a bit less proclination. And then you can adjust it by bending this wire here. Sometimes there are many ways you can adjust the system. I was also, people ask me, why did you use the system here? I could have put the wire a bit longer here. You see, the advantage is I got good support. I'm rotating the teeth this way. So I'm uprighting the molars into a better position. And I'm just working, at the moment, I'm just aligning the upper teeth. I'm not doing anything on the upper. So then I'm starting to work with the retraction mechanics. I tried to go straight wire on this as soon as I got, as soon as I got a good occlusal plane. I tried this, but you see, again, it's starting to close back on me. So maybe I was a bit too quick on the straight wire retraction system. I'm losing the midline a little bit, so it's not as good as it could be. And again, I'm just looking at the lower arch. You can notice that I'm not doing much on the upper. All right. And then this is the, I'm starting to work the vertical. It's still not looking very good. So I say, wait a minute, we need to be better than that because we're not going to be finishing in the right position. So that's something that I need to work up. So then I decide to use an intrusion arch for the upper. So the intrusion arch is right here. So then I get this kind of force. I'm rotating the anterior segment this way to get what I want to do. So this is a dual wire. So I go under the brackets and it's just tied here and here. So I'm starting to control the incisors. I decided the upper incisors have to go up, and I'm still working up the wires. I'm working with sliding mechanics on the lower, looking at what can be happening. Okay. And then you see the results. So now I have pretty much leveled the lower arch compared to where it was before. I kind of lost the midline a little bit. You see, there is always, as you all know, we tend to close the gaps sometimes faster one side than the other. So I need to stop closing the space here, and I need to concentrate on this side. So that's why I have a spring on this side, and I don't have one on this side. I'm going to shift the midline this way. And it's all on the same plane. So I'm working in two planes of space. At the same time, I'm working the vertical for the patient. And this depends, again, you have to, like my good friend from Boston was saying, you have to use your vision of saying where are these teeth moving and how can I make the case as good as it can be. So she's getting better. All of a sudden the lips start to drop. She's getting a little bit better, even if I don't even retract the upper incisors. I'm just working the vertical. And that's important. So now she's starting to like what I see. It's been about 13 months in treatment. And you can see now that I've stopped again not stopped, I'm using a different system, but I have a dual wire to control the vertical again, because this is going this way. So by going this way, it tends to rotate this way, which is not what I want. So I'm adding a vertical force to get this type of retraction. So this F1 and F2 are used to get what I need to do. And I'm going slowly, and it's working pretty well. So I'm going to go quickly because I'm done by 30 minutes. And we go forward, we keep on controlling, and this one is just a sliding mechanic system, nothing special. And it's a matter of now closing the spaces, and you see the spaces are pretty much the same. So it's either I will promote molar protraction, or I will promote incisor retraction, or a little bit of both. So now it has become a simple case of basically just retraction of incisors or protraction of molars in two planes of space. And this is where we are. So I'm working at it slowly. And you say, okay, so what have you done? Well, we went from 89 here to 190. And what happened is I wanted to stay between 90 and 95, because I wanted this teeth to come forward a little bit. And I wanted this one to go this way and this way. So did we succeed? Yes, we are getting better. So the uppers are doing pretty well. They could intrude a bit more. So basically, we have to, again, work the vertical. So I cannot let this teeth over erupt, because otherwise it's not going to work. And these guys are at 96 now. But remember, we still have some space here. So I round tripped a little bit. So now I can bring the teeth back a little bit. So that's where we are. We still need to open the bite. We still need to intrude these teeth. But they should not go this way anymore. They are done. Okay? So now it's going to be a matter of torquing and getting the teeth correctly retracted. And the roots are still there. We intruded the teeth, and we don't have any root resorption. I think that's good. Nothing here too. So that's good too. The roots are still there because we use very light forces. But the main idea, and I won't show you the case finished because it's not really finished yet, but the main idea is, okay, all this is orthodontics, right? We're very happy, but what about the patient? What does the patient see? And that's especially for adult patients. It's very important for them to see some results. So where is the patient now? Now we just need to finish some space closure. There's not much left to do. A little bit of intrusion, a little bit of retraction, and we're done. But really what happens is this. This patient came from here with low self-esteem. She hated her smile, she hated her face. Now we start to retract the teeth. Look, and she lost some weight. The lips has actually dropped because of the retraction. And she looks very nice, and she really likes what she sees. And this is what we get. This is not a surgical case. This is an orthodontic case. That's what we ended up doing. So again, I want to thank the audience. I will now listen attentively to Dr. Nakajima. So in conclusion is, this real intrusion is good. Rotative intrusion is good too. They both have merit. It's the orthodontist that makes the call. You make the decision. You can say, I only intrude this, or I don't care. I will just level and align and let nature help me, or the wires help me. You make the decision what you want, and you can vary during the treatment because the patient response is not always the same. You have to plan the case carefully to address the problem the way you want it. And obviously you control the incisor position in 3 planes of space. You control the upper and the lower as much as possible. And sometimes using just straight wire and class 2 elastics is not good enough. Sometimes it is, but sometimes it's not, okay? And what I say is, as a last conclusion, you do not trust wire sequencing and indiscriminate leveling in all cases. Sometimes they work very well, especially on growing patients. On non-growing patients, you have to control the occlusion and the incisor position in 3 planes of space. So I will wait for questions. I will stop sharing my screen, and I hope you enjoyed the lecture. And I thank you for your attention. Thank you. And I thank WebsFX for the invitation. And now I'm going to be listening to my good new friend, Dr. Nakajima, with very huge interest. Thank you very much.
And turn on your mic.
Okay. I already cut the mute. Can you hear me?
Yes, we can.
Okay. Let's go over my one is a brachyfacial type. 13, it depends on intrusion and lower intrusion, upper and lower incisors, but it depends on, we have to think about the different type of a facial type. So first things is brachyfacial type, 13 years, 3 months. Look at very deep bite. And here's the case, the mid-treatment. Last slide I saw, Dr. Retrovery said almost he used the same things and looks like a utility edge. This is a simple utility edge of the Dr. Ricketts. Intrude upper incisors, and this is the lower is advancing and lower intrude lower, but also intruding up and upper incisors and tipping forward. It is meaning is a tip back. Also, they're going to tip back upper molars. So for we don't like tipping up upper molars. So this is a simple straight section, like stabilizing section. For intruding upper incisors, like here, and but that force will tip back in the upper molars. But also, if we use the same time simultaneously lower, simple stabilizing utility arch, tip forward bend and to the straight section. So we can control upper molars stable. The same thing we can use the lower stabilizing section too. This is the result after the treatment. So we could get the nice upper and lower incisors relationship like that. So let's think about what we done and what we thought. This is the T1 VTO, only superimposed number 4. This is upper part. This is the lower incisors part. So let's think about the lower incisors part. So brachyfacial type people has a very bulky tendency symphysis. And so we have a little bit more spaces, free space, this direction. And so I tried to intrude a little bit and tip forward a little bit. And what I did was actually is look at this. Just a little bit intrusion and mainly tipping forward because brachyfacial type people, patient, it's very difficult to close up open the facial axis or low facial height. So we have to we shouldn't plan to only just intruding lower incisors, only simply incisors. It depends on the fissure type. If the patient has a brachyfissure type, we have to mix intrusion and advancing, inclining to the labial. And case 2 before the treatment, male, 23rd, 0 mount, non-extraction. Also, class 2, class 2 and deep bite and very deep bite, and the class 2 division 2. But this patient has shows a mesiofacial type. A mesiofacial type patient has normally has a middle type of shape of symphysis. So we have to non-extraction headgear. No. This is the stabilizing section plus intrusion and torquing our utility arch and the class 2 elastics. And this is also the same tip forward bend and upper stabilizing section. So this is the result. The final, this is still using the normal utility arch, intruding upper arch, and to correct the result of the upper stabilizing section, the upper canines is extruded downward a little bit. So we have to correct in the tip it back to the upward and to L loop. And lower is just a titanium wire. This is a result. So I also like a very simple mechanics instead of multiple mechanics. But simple mechanics is very simple, but it also works very clearly. This is the result, the patient, class 1, and the good up and lower incisors relationship. And now let's talk about think about what we thought and what we really did. The upper part is the T1 to VTO. So we tried. This is the typical mesiofacial symphysis. So mesiofacial symphysis has a little bit space we can intrude here, and no, this is so. And the lower part transparent sheet is the T1, T2. That means an actually I did. So this is the not only intrusion plus tip forward like that. Because of that, mesiofacial type has a mesiofacial relationship and a good relationship with facial type. So we shouldn't break up that relationship. So next, this is the case 3. Female, 45, 8 months, and very deep bite, class 2, division 2. Look at this, her, here's the osteo damage. She had been damaged very long time, but also she has a dolichofacial type. Dolichofacial type with deep bite is the most difficult treatment. You have to care about that. Total facial type is very easy to open up their facial axis. Look at her lower incisors, very damaged. That means she had suffered from the of TMJ problem many years, I think. So, but mechanics is the same. Upper utility arch with a little bit this is an advancing loop and stabilizing section. This is the almost the final stage of her case. This is the final result about 47 years, almost 1.5 years of treatment. And this is the T1 VTO, just a slight intrusion and the tipping forward. But what I did is more tipping forward like that. Today, I spoke only about the up and lower relation only, but mainly this relation came from the upper molar relationship. Usually, upper molar, the Dr. Ricketts said, the Dr. Ricketts analysis has upper molar to PTV. The upper molar to PTV is the most important part of the analysis, I think. And usually, if we think we don't have enough space upper molar to PTV, we have to put it back or headgear or any kind of tool. So we have to come forward to get the good gravity. So the why we have upper molar position is existing that such a place is to maintain their to release the gravity toward to the brain. So the position of the molar position is the most important purpose of in our orthodontic treatment, I think. That's a very roughly speaking of me. Yeah. And I have some very short speech, but some movie in short movie. So maybe Jay will show you at the website movie. Okay.
Yes,
Not now.
yes.
Later on, I think.
Yes, I told you I will post your video on our WebSite group and website, and I will share it through the WhatsApp group. Okay. Thank you so much, Dr. Retrovi and Dr. Nakajima. I really appreciate your effort, and it was a meaningful time to learn about the clinical meaning and role research intuition in orthodontics. Since we have to have speakers for today, why don't we have some time to discuss about the lecture? Meanwhile, I'll collect some questions from the chat box and post them on the screen. Then Dr. Nakajima and Dr. Toby will be answered. And as I told you guys, Professor Chin will handle our question and answer time from now. Thank you, Dr. Jin.
Yes, thank you, Dr. Nakajima. for the lecture. So we have questions in the chat. So put questions in the chat for whoever. I think we've got one from Abdel, I think, right now. Why is that we can only intrude by 3.5 for both maxillary and mandibular teeth? I didn't say that. I said that Dr. Carlos Muir and Major from University of Edmonton did a systematic review, and they found that the average intrusion is about 3.5 for both arches, which means that you are limited in what you can do. And as Dr. Nakajima said, depending on the facial type, some people, if you have a big symphysis, you can probably intrude more. But remember that the intrusion tends to be the one that has the most resorption. So you have to control really nicely where you are going to be putting your intrusion forces. Sorry, my camera is too low. Okay, so that's the idea. It doesn't mean you can't get 3 millimeters, but you have to control. So I would say that if you want to intrude more than 2, take a ceph, make sure that the roots are still in the bone and keep on going. If you feel that there is a problem, then please stop and then reserve, even if you have to more extrusion. I don't know what you want to add something. Dr. Nakajima, to the question. He's asking about what the limit of intrusion for incisors.
I think
Intrusion is more predictable and efficient. Well, my opinion, if you, for incisor intrusion, you can use TADS, but the intrusion, it depends on, as Dr. Nakajima showed and I showed, you have relative or real intrusion. You can procline the teeth. So it's more in the studying of the case where you want the teeth to end up, and depending if it's a simple proclination, you don't need TADS. If it's a real intrusion and you don't have any, and I showed that you can intrude the teeth pretty well without TADS. I think my opinion at the moment, maybe Nakajima agrees with me, I think TADS are overused, because if you have good biomechanical principles, many times you don't use the TADS for incisor intrusion. You do need TADS for molar intrusion, because it's very hard to do without TADS. But for incisor intrusions, if you need very light forces, and with good mechanics, you don't need the TADS. But because people all use straight wire systems, they need to add the vertical component of force, which is given by the TAD anchors. So I rarely use TADs for incisor intrusion because I don't need them. For molar intrusion, I always use TADs. Okay? Again, Dr. Nakajima, you want to add
I
something?
think so. I agree you. The TAD intrusion is not our final purpose. Intrusion is just a small position, I think. The most important things how we end up that case as on the reasonable physiological or result. So the first thing we have to think about the total diagnosis and the position of upper molar. The upper molar position is the most important. So many of class 2 cases need more space, PTB, PTB to upper molar, usually 18 millimeters and plus minus 3 millimeters. That's the average of the upper molar position. So we have to think about how much we need intrusion and upper molar and lower molar is. Start from the upper molar position. And Dr. Retovary said the most favorable gram of lower incisors for intrusion is 60 to 80 grams. That means one tooth needs 20 grams, and 20 grams plus 4 is 80 grams. So maximum is 80 grams. So if you use the TAD and plus rubber band and intrude upper, it takes it makes more power to intrude. So that makes you easy to lose your result. Did I? Can you follow me?
Yes, it's very good. But what you're saying is you put too much force. And also many times the TAD is not, the line of force is not really where it's supposed to be. So you have to calculate line of force. And that's what is important. So TADs are good. It's part of the biomechanical system. But again, relying on wires and TADs, if you don't know where the force is applied and the direction of the force, it's not good. It can be very good or very bad. It depends if you understand the line of force, the line of action of the force, and the magnitude of the force. That's very important. We have another question. Do you prefer Burstone three-piece intrusion arch? Yes. It's very good. The Burstone three-piece is a very good appliance if you really want to do some pure intrusion of the upper incisors, and you do not want, and you want to really control the line of action. So you can vary, the three-piece allows you to vary where you are going to use the cantilever position. So you can rotate or not rotate. There are many things. The big problem I'm having with the three-piece, and I don't use it as often as I should probably, is some patients don't like it because it tends to give us more problems. Not so much mechanically, more like emergencies. So that's why I don't use it as much as I should, because I like simple. And the Burstone is fantastic. It's just a bit more complicated to maintain for the patient, but it's potentially the best. You want to say something, Dr. Nakajima?
I think intrusion. Somebody says on intrusion upper arch, the limitation, something like that. The incisor line, the smile line, and the lip line is very important. So we have to think about not only the relation of upper and lower incisors. We have to think about upper and lower lip or more muscles. So I'm using many PNF, proprioceptive neuromuscular facilities with orthodontics. That makes you more, get you more good relationship teeth and muscles.
Another question, can we use removable appliances in addition to fixed? Well, the one I use the most myself is the anterior biplate. Sometimes, again, it's a very good appliance if you want to extrude the molars. It's not so good if you want to intrude the incisors. So I don't use removable appliances for active lower intrusion. It's more for, let's say, on a patient that you want to extrude some molars. And again, there is some controversy extruding molars because some people say it's not stable, but I don't know. I think I use a lot of removable for molar extrusion in growing patients, not so much in non-growing patients, but sometimes you have to. So I use that only for this. I don't see any other indicate, or if you want to tip back incisors that are, because you have a habit and the incisors have been over proclined and you just want to bring them back and down, that's the removable appliance will work really nicely, but it's limited in its possibilities. Dr. Nakajima?
Yes. I'm also a lot of many removable appliance and growing child, but that's we call biospecial, just like a template. And before we going into the real orthodontic treatment, we have to readjust our muscle and other problems first. Then we can get into teeth contouring. So that's why the first step I'm going in, I'm using a biotemplate, then a lower biotemplate and upper quad helix. Many cases has upper front teeth crowding case has showing a molar mesial rotation. So because of the mesial rotation, they cause front teeth crowding. So expand a distal rotation with the quad helix, but we don't want to open up the facial axis. So I think we better to use the biotemplate with the simultaneously that keep their bite the same stable or facial type facial axis. So that's the only way, only one I'm using the plastic removal appliance.
Okay. Thank you.
Is that okay?
Another question. Intrusion of upper incisor can affect the smile arc. How do you reduce such effect on smile arc during intrusion? Well, there are two different things. You have to intrude. If you intrude straight and you don't do a good job of intrusion, you're going to get a very square smile, and that's not very aesthetic. So you have to intrude the teeth and maintain the smile within the envelope of the lips and the muscles, as Dr. Nakajima is saying. So your intrusion arch, or even your straight wire, has to take this into account. The smile arc is, there is no one smile arc. There is a smile arc for each patient. So you have to treat the patient and adjust your mechanics depending on what you do. And you're totally right. If you intrude the teeth very simply, you end up with a square smile, which the teeth are the right place, but they don't look good. So it's a matter of mechanics. We don't have the time today for that, but you're absolutely right. The smile arc has to be respected, and that's why you will notice that I changed a lot my wires during the course of the treatment, so I adjust depending on how the soft tissue react, and they don't always react the way you think they will. Dr. Nakajima?
I think too, the smiles that came from teeth. Smiles came from muscles, nerve. So we think about the train our nerve and muscles simultaneously with adjusting teeth. So if we don't forget to train nerve and the muscles, we can get a good relationship end up after the case. That's my opinion.
Okay, that's fine. Reverse curve speed, how much useful in intrusion? They are useful in some cases. If you read Dr. Troy's book on biomechanics and Burstone, it's biomechanics and clinical orthodontics, he describes very well. My opinion, the reverse curve speed is overused. We use supposedly intelligent wires, and the problem you have is in some cases the curve speed designed into the special wires you use, the reverse curve, is useful, but many times, especially in the cases I showed you, it would have worked. There is no way you could work with a reverse curve speed. So the reverse curve is okay if you have a moderate curve speed, you just want some molar extrusion, some molar uprighting, and some proclination of incisors. But in reality, many times the reverse curve in complicated cases is not as good as you think. That's why I don't use many reverse curve speed, because you tend to over-procline the lower incisors. That's my opinion. And they tend to resorb the roots a lot more than the average intrusion arches, because you put too much force on the teeth.
Yeah, I don't use the reverse curve much, because if we use the reverse curve in dolichofacial type, that push you more open up the patient facial access. So if you can use only case you can use reverse curve is probably brachyfacial type is better. So I think reverse curve is not useful mechanics in nowadays.
No, you're right. I agree with Dr. Nakajima. I've used a lot of them at the beginning, 20 years ago, 15 years ago, and I didn't see the result I wanted to see. I don't like the wire to decide where the teeth are going. I like to decide myself. So I don't like intelligent wires. I know reverse curve are popular, and that's fine. But if you want to get the results I show, I'm not sure reverse curves will do that, because you don't control. You just put the wire and hope that it will do what it's supposed to do, which in my opinion is not optimum. It's not bad orthodontics. It's not optimum orthodontics. The next question is, how real intrusion possible with clear aligners? Yes, it is, but it's unpredictable, unfortunately. Again, like Dr. Nakajima says, if you have very brachycephalic patients, it's going to be much more difficult. The clear aligners will put forces. So if you use intrusion arch, you have to use the same principle as an intrusion arch. You have to put a lot of attachments in the posterior teeth, and then you bypass the canines and you put very small force on the incisors, and you only adjust about 0.10 millimeters, 0.1 millimeter for the aligner, and then you concentrate on extruding only. Otherwise, if you do too many things, the aligners can do it. So I have been sometimes successful, sometimes not successful, and I still can't explain why it works in some patients and why it doesn't in others. So aligners is always a mystery for me for the success. But theoretically, they are very possible, but make sure you put a lot of attachments in the posteriors if you use aligners for intrusion. Dr. Nakajima?
Yeah, I don't use aligner much, because the same as the wire too. A wire doesn't have a brain. Aligner doesn't have any brain. I want to use my brain.
Yeah, no, you're right. But I mean, again, it's unpredictable. I think we're going to get better with aligners. It's just that exactly we have to put brain into the system. Do you think there was a question that I didn't see from Larbi? Can you intrude lower incisors through the axis? Real intrusion, if you do not have space, no, you have to make space. Otherwise, you have to procline. Otherwise, you do IPR, extraction, whatever. You cannot intrude teeth if you have real intrusion requires space. You're absolutely right. Dr. Nakajima, you want to add something? No?
Yeah, I don't like IPR.
Well, but sometimes you have to do it if you want to make
some case needs a little IPR, but many aligner people, the purpose IPL is one of the tool.
Yeah.
So the reason why we have to align the teeth is to align the contact point. Align our contact point. If we cut off the contact point, we lose our signal to the tooth to the central nervous system. That's the worst way, losing the contact point.
The last question, I think, what do you think about the detorquing chain, elastic chain to intrude the incisors? I have no idea what it is, so I'm not going to answer that one. I don't know what a detorquing chain is. So torque needs 2 points of contacts and 2 forces equal and opposite. So I don't know with the chain how you can do that, but maybe there is a trick to it that I don't know. Maybe Dr. Nakajima knows.
I don't either.
Yeah.
The simple force. You can't torque with a simple force. It's not happening. Or maybe if you have 2 chains pulling in different direction, torquing needs 2 forces equal and opposite at a distance and away, and with the 2 line of actions parallel at a different position. So torquing is not feasible with 1 chain. So it's not detorquing. It's got to be something else. But maybe there is something I don't know. So I'm not going to answer this one. Is that all right, Dr. Park? Any more questions?
Yeah. No, thank you for answering the question kindly and patiently. Professor Jin and Professor Nakajima, you doctors sure are professional, I think. That was our question we prepared today. Now we will wrap up the webinar if there are no further questions. Thank you everyone for your support. For a while. WebSedX prepared something as a sign of gratitude with a certificate of appreciation. We are really impressed by you, doctor's effort to share your valuable knowledge with the world. Well, Dr. Nakajima and Dr. Shin, do you have something to say to the attendees before ending?
Dr. Nakajima?
Thank you very much for attending our joint lecture. I think we could get a good discussion, but intrusion is not so simply. So I think our purpose is not only intrusion. We have to get the final purpose is a good relationship with the central nervous system and the muscle and nerve and occlusion. That's it.
Yeah, well, I thank Dr. Park for the invitation. That's my second time with the WebSedX. It was interesting.
It was great.
Good audience, good questions. Unfortunately, all the questions cannot be addressed in such a short time. But what I want to emphasize is orthodontics is much more complicated than it appears. We make it so simple, but we get, I would say, inferior results because we don't apply the correct biomechanical principle of Dr. Burstone and all these giants of orthodontics. And I think it's time for the audience to revisit these concepts and apply them to each individual patient. Do not fit your patients to your treatment. Fit your treatment to your patient, please. And just make the best you can and always improve by taking those webinars. I mean, it's a great educational tool. Hopefully, I was able to add a bit more knowledge to what you already know. Otherwise, apologize. And I had a good time with Dr. Nakajima and Dr. Park, so I look forward to come back another time maybe one day. And have a great day or a great night, wherever you are in the world. Thank you very much for the attention. Now I'm going to go teach my students.
Yeah. Okay. We will end today's webinar at this point. It is miracle time for me and the members. We have about 200 members from all around the world. Yeah. Thank you everyone for attending today, and special thanks to Dr. Nakajima and Dr. Chin, our speakers.
Bye.
Hope everyone stay safe and healthy until we meet our next webinar. Bye. Thank you very much.
No problem.